Okay, I think we'll make a start in the interest of time, and I think a few more people will probably come in a few minutes. Thank you ever so much for joining us today for this event. Time is tight, and it is my job to make sure we get through the agenda. But I did want to say a few things just before we start, and particularly before I introduce our keynote speakers for today. The first thing is to thank the SHARE Research Consortium, which has organised this meeting. And within that consortium, two partners in particular. The first, obviously, the London School of Hygiene and Tropical Medicine, which is where we're at today. But the other partner is WaterAid, which is an international NGO working to improve access to safe water, sanitation and hygiene in over 30 countries around the world. By way of introduction to this paper and the issues that we're going to discuss, I wanted to say three things. And then after I've said those three things, we're going to watch a very short 2-minute video that was prepared by WaterAid Tanzania to hopefully focus our attention on the critical issues. The first thing that I want to say is that water, sanitation and hygiene, which are going to be referred to as WASH, firstly that WASH, it's a really simple thing, but it's a really important thing. And in the context of maternal and neonatal health, it's important in terms of infection control, but also more broadly, as these services are important determinants of the quality of care and how acceptable and indeed appropriate health facilities are to women, particularly pregnant women. Simple things, as we all know, are often forgotten or neglected, or they can become someone else's job, and I think that's one issue that we're going to talk about today. The second thing that I wanted to flag is that this is not a problem that's going to be solved by cross-sectoral finger-pointing. Solutions require participation and engagement and support from across different sectors and, of course, different ministries at the national level. And one of the great strengths, I think, of this paper is that it brings together authors from both sectors, from the WASH sector and, of course, from the maternal and neonatal health side, but also from leading international agencies and academia. And this, in my mind, makes this call to action really quite powerful. The last thing I wanted to say before we start is a question, really, rather than a reflection. And it's a question that Alexander Gordon, or in fact Ignác Semmelweis, might have asked if they were here today with us, which is, why are we still talking about this basic problem? Both their names, you may have noticed, are inscribed on the facade of this building because they played instrumental roles in identifying that puerperal sepsis was transmissible via the unhygienic practices of doctors and midwives. Semmelweis, as many of you will know, even designed and tested an effective intervention that led to dramatic declines in maternal mortality in the hospital where he worked. So why are we still talking about these problems? Is it that we lack sufficient evidence? Is it that we lack effective interventions? Is it because the costs are too great? These are some of the questions that I'd like our panel and our speakers to think about, and indeed the audience as we move into the discussion. Right. Before we do hear from our keynote speakers, as I said, we're going to have a very short film that was prepared by WaterAid Tanzania. The reason we're showing this film is that there is a tendency to lose sight of some of the basic realities of these issues in events such as this. And the authors of the paper, who are both academics and people representing policy international agencies, thought it would be good to start with this film to maybe ground some of our discussions. Yeah, my apologies to the panel. It's rather difficult for you to...
Ilikuwa ni furaha kubwa kwa sababu nilikuwa nimebadilisha uzazi kutoka kwa watoto wa kike kupata wa kiume. Huyu alifariki. Mtoto alizaliwa na kilo 3.5. Alikuwa na shida yoyote. Tatizo litokea tu hapo kwenye kitovu. Nilijisikia vizuri tu kwa sababu nilikuwa sina tatizo lolote. Afya yangu ilikuwa safi. Nilikuwa na nguvu. wakati wa kujifungua hali ya maji ilikuwa ni ngumu. Baada ya kujifungua, nguo zilifuliwa pale pale na mtoto alioga pale pale pamoja na mimi mwenyewe. Kutokana na maji ambayo wifi na mwenzake walienda kuchota mtoni. Kwenye mto huko ambapo wanasema ni mashimo tu yamefukuliwa kule mtoni kwa sababu ilikuwa ni kipindi cha ukame. Kukawa maji hakuna tena mtoni. Kwa hiyo ufukue mchanga hivi ndo maji yatoke chini ndo chote. Kwa hiyo ndo maji yaliyotumika siku 7. Ni sawa maji yangekuwa yapo, naona hali ya maradhi isingetokea kutokana na usalama wa maji. Kwa kweli inatia huzuni kwa sababu ilikuwa sio matarajio, lakini kwa sababu imetokea basi.
Okay, I think hopefully that film really helps to bring these important issues into a clear focus. It gives me great pleasure to introduce our first keynote speaker for this evening. It's Dr. Jane Edmondson. Jane is the head of the Human Development Department at DFID's policy at the UK Department for International Development's Policy Division, and that puts Jane in a really interesting position because she sits across health, water, sanitation, hygiene, nutrition, and indeed education. So really has an eye to, the difficulties, the challenges, but also the opportunities of coordination across sectors. Before joining DFID in London, Jane was the deputy head of the DFID Pakistan office, and at some point in the not too distant past was here at the London School working on issues around malaria. So Jane, we're really pleased to have you here. If you could come up.
Good evening, thank you. Thank you for that nice introduction, especially promoting me to doctor. And thank you everybody coming. I know at this time of year there's lots of other nice distractions you could be spending your time doing, so it's really good that you turned out for this important event. And thank you very much to the organisers. I'd also like to thank Dr. Maria and Eric in what is a very tight schedule, I gather, for coming along. It's really good to sort of see WHO leadership on this and look forward to hearing what you've got to say. I'm very happy to be back at the school to do another event organised by the Share Research Consortium. We're very happy to be supporting Share, and I'll come back to that at the end. Share is all about equity and finding the best ways to achieve universal access. Last time I was here, I was talking as part of a panel that was discussing how WASH programmes can help prevent violence against women with simple practical steps backed by good evidence. And here we are again looking at another area where improving and joining the dots better can have a big impact on another area of well-being. As was mentioned, I head up a department in DFID's policy division that covers health and WASH and nutrition and education. So it's a large part of what I do is looking at what dots need to be joined up across those things. I have teams that work separately on all of those things. And a few people who spend their time trying to join the dots between them, and that's an incredibly difficult thing to do. And we don't live in a very tidy world. It's not possible to join up all the dots. So another part is what are the most important dots to join up, and how do you know which are the most important dots to join up? They'll have the biggest impact and the best value for money. And the big thing there is around evidence about impact and value for money, and how you can do those things, because it's not easy to do. And so we're here to mark the launch of this important new paper, which is a really important part of that evidence piece, calling for action on WASH and linking it better with maternal and newborn health. The paper builds on a number of studies supported by SHARE, which has been published recently, and really looking forward to hearing from some of the panel members more with their reflections on all of this. What was really good to see in the paper was the mix of authors from WASH community, the maternal newborn health community, from academia, from the policy world, and that makes it a really important paper in terms of the credibility it's going to have with the multiple audiences that need to be taking action as a result of all of this. It also demonstrates, even if it's just about getting an evidence piece together, that those pieces of the picture can work together to produce something, and that's really important. So I just wanted to pick out 3 points before moving on to the other panel members that I think are coming out and are going to be very key to moving this agenda forward. One is, it's a very stating the obvious thing to say to a room full of academics and others, is that evidence really matters. This paper reviews the evidence, acknowledges the gaps, and gives out a strong and credible message that there's enough evidence to suggest those 2 dots of WASH and maternal newborn health could and should be joined better together. And it's not just about establishing a link, and this is where I'm speaking as somebody who is in a policy division, has a job that's about shaping policy and putting it into action. That just establishing a link does not convince our policymakers on its own. There has to be, sort of credible and practical suggestions for how you do that. And so moving on from that is a very important next steps, and that needs to happen alongside gathering more evidence. The second point is that there's a really strong, and this is another reason why this is a good set of dots to join together, is that there's a real potential win-win here. It's always really hard to follow a video like the one before, because that's the most important speaker you're going to hear this evening, was that woman talking about the issues and the awful tragedy that she had to face through a lack of decent water, sanitation and hygiene and care around the time of birth and shortly afterwards. There's a huge numbers of people who are left behind we've made some good progress on the MGGs, still left behind both on the maternal and newborn health targets and also on the WASH targets, 2 of the most important areas to continue through the other side of the SDGs to finish the job, leave no one behind. And I think one of the ways in which we can make sure they're not left behind is by joining these things up much better together. Still far too many people. So if we can prioritise WASH within maternal and newborn health services, both at home and in the health facility, and in the process really raise awareness about the general benefits of WASH much more broadly than just maternal and newborn health, there must be a really good win-win there, and I think we need to find ways to make sure that actually happens, because win-wins are easy to talk about, they're actually really difficult to bring about. The third point is that there are identified concrete steps here, and what the paper I think discusses a lot about a window of opportunity around the SDGs, and I think that's really important. There is a window of opportunity around the SDGs. I think I'd probably disagree slightly that it's our only moment, our only window of opportunity. If we don't seize it, it's disaster, because I think these conversations have to persist and continue through, and just seizing that moment is not enough on its own. Or in some cases necessarily the most important thing to do, but there is an opportunity here, and we've got language in the Open Working Group report about those things, and I think there'll be a lot of work around means of implementation over the next few months, and I think it's an important opportunity to identify those dots that are most important to join together. And I say a little bit about that because I think there's a tendency to sort of think of policymakers as people over here and then practitioners over here, and that's in thinking about how to make the most of this. I think it's quite important to break that down a bit, because policy these days is made in all sorts of ways. It's made through increasing practice and just showing and sort of bubbling up from the bottom. It's made by politicians, it's made by officials, it's made in all sorts of ways, and thinking about that very carefully. And policy shapers, in a way, are almost more important than policy makers, because usually by the time it gets to a decision, the decision's fairly clear. So I think thinking about that quite a lot is really important. And going back, there's also kind of, why do the dots join together? And I think it's because people, comes back to human nature. We work in communities. There'll be people in this room who think of themselves as part of the WASH community, people who think of themselves as part of the maternal newborn health community. When I go around the world, I have very, very few counterparts in other organisations. Organisations tend to be very siloed, and that's part of the problem, is that there aren't that many people around whose job it is to join the dots. So some of you, I really join the dots community. There need to be people who sit in between and are doing that, and I don't think there are enough of those kinds of people. So I think that's one really important thing. Finally, I said I'd come back to share. Wanted to use this opportunity and mark this important by announcing that DFID is going to be extending its support to share out to 2018. It's a decision that was made recently, and we're very pleased to do that, because we recognise that this is an area where we need to continue to build the evidence. We've got examples within DFID where we're trying to do this joining up, but it's not going to be enough. The really important thing is to kind of make a major shift to make sure that this is something that just becomes natural and obvious to do. So on that note, I look forward to the discussion, the questions and answers. Looking forward to hearing a lively discussion from the other panel members. Thank you.
Thanks a lot, Jane. That's a really good note to start the launch. And I think you made some really important points there about the importance of joining the dots, but also recognising that we're not going to be able to join all of those dots. So which are the really critical ones that are going to deliver results in the sort of short to medium term? Our next keynote speaker, we're very lucky this evening to have two keynote speakers. Our next keynote speaker is Dr. Maria Neira from the World Health Organization. And about 3 or 4 years ago, I was actually chairing a launch event for a different paper here at the London School. And Maria arrived in dramatic fashion after her. I think your plane had been delayed because it couldn't land because there was fog and ice, and you sort of came running down the steps about 20 seconds before you were due to speak. So sort of somewhat less flamboyant entrance this evening, but it's really nice to have you here. For those of you who don't know Maria, Maria was a medical doctor by training, and before joining the World Health Organization was actually the Vice Minister for Health in Spain. And since 2005, she's been the Director for the Department of Public Health, Environmental and Social Determinants of Health at WHO, so a really big job. Despite the breadth of her portfolio at WHO, in the last year she really has personally championed the particular issue of water, sanitation, hygiene in health facilities. So I'm really pleased that you're able to make time to join us this evening. And please.
Thank you very much, Oliver, and thanks for reminding me about my flamboyant entrance. I forgot about, and sorry if today I didn't have anything so spectacular, but I have to leave early. That might compensate. I will try my best. Sorry, all of you. Good afternoon. You need to switch now for a beautiful British accent to a Spanish type, and I'm afraid this is how the world is today, so you have to adapt to my terrible accent. But I'm trying to learn your beautiful British accent. I'm very pleased to be here today and in a school because, in fact, I started my career as public health officer dealing with cholera. So this is the perfect room to be when you were called in WHO, and this is a secret, please don't disseminate. They used to call me in WHO the fecal point of the organization because I was dealing with cholera and other epidemic diarrheal diseases. Somebody has to deal with those issues which are not very attractive, but you know, it was a very good exposure to public health. And in fact, my career takes me again to the basis of diarrheal diseases and putting the docs together. I'm very pleased to join your invitation to the club of those putting things together. In WHO, our department is the one trying to do that and to make sure that everybody understands that when you talk about maternal mortality, newborn mortality, nutrition issues, if you don't address the basic pillars of our public health, like access to safe water, sanitation, and you put the two communities together, you are doing a very poor work on that. I loved the video. I think it was extremely powerful, but there was something on the message that depressed me a lot. And it's something that I saw myself many times in Africa. The way the woman finished the video, do you remember? She says, I was not prepared for that, I feel very bad, but this is the way it was, I accepted it. And this is something terrible. She accepted her destiny. She accepted the fact that she doesn't deserve a healthcare facility with safe water and sanitation. She's too small for having a healthcare facility that will take care of something that is a question of human rights and dignity, and the minimum a woman that goes to a healthcare facility will expect to have safe water and sanitation, and hopefully some soap to wash your hands. And in fact, I'm sure we all agree that this is so essential and so basic that doesn't deserve any discussion. But unfortunately, this is the wash services are still very much neglected around the world, and particularly the healthcare facilities. And in fact, the WHO Global Review of the Water, Sanitation and Hygiene and in healthcare facilities indicates terrible figures. We were looking at particularly 53 low-income countries, and we found out that around 40% of those healthcare facilities will not have access to improved sources of water. And they will not have access to sanitation. And of course, if you want to wash your hands, you don't have soap. First of all, you don't have. This will have an incredible effect that, as you can imagine, you don't need to have a lot of imagination to see that when a healthcare facility is created, is to provide health and to take care of people. And in fact, sometimes you are the one responsible for the infection that the child of this woman went back home with. So this global survey we did, it was probably one of the most dramatic ones, telling us something that shouldn't be acceptable in 2014 or 2015 as we are now. We have another fact that to put on the table. Policies and monitoring are still weak. And I think, Jane, you were very right on this issue of putting the dots together. Is probably one of the most difficult tasks of putting the different sectors working together and challenging each other, maybe using health as an indicator to prove that the investment by the sector on water and sanitation is appropriate. And this is something that our report that I'm sure you know very well, the GLASS report. You are students or academicians, so I'm sure you know that is Global Analysis of Assessment of Sanitation and Drinking Water, the GLASS. And the GLASS proved that only 25% of countries, they have a plan that is fully implemented and reviewed on water and sanitation. So we still have a lot to do in terms of policy and monitoring, because they are still and those policies, when they are in place, they prove to have very good results. Obviously, again, another message that I think everybody will agree, better wash equates healthier mothers and newborn. And I will not stop there. I'm sure that will provide even benefits on many other issues. Nutrition, there is no way to provide nutrition if you cannot cook with clean water, at least. There is no way to have a minimum of prevention of infections at the healthcare facility if you don't have a minimum of safe water and sanitation. So for us, we need when there is access to wash, you have a higher level of mortality, when there is a lack of wash, a higher level of mortality for maternal and newborns. It's true that we might still lack randomized controlled trials on the subject, but if you ask doctors working on the field, and I'm sure that many of you have been working on the field, you know very well that delivering a child without access to clean water and sanitation is almost impossible. And I've been myself on those conditions, and I don't want to repeat that experience. I think it's totally unacceptable to help a woman to deliver with a kerosene lamp and without access to proper safe water and sanitation and soap to provide a minimum hygienic conditions. And in fact, in addition to that, when you equip mothers in the antenatal advice, and you help them to change their behavior, you provide them with tools to take at home, to have ways to keep the water safe at home, this behavior improves and they have a lot of positive results on the cleaning the environment at home and then creating these simple tools that can provide a lot for pregnant women and increase with, they will seek for care at the healthcare facilities because they are looking for clean and hygiene conditions and better conditions than the one they have at home. So for us, therefore, WASH in healthcare facilities, for WHO, and I'm sure for many partners gathered here today, is a critical function and a critical priority. Margaret Chan, our Director General, has already declared that improving WASH in healthcare facilities is an urgent priority. And in our department on the public health, social and environmental determinants of health, we are working towards that. And we initiated a global action plan. Some of you have been in Madrid joining us for that, looking at how to improve WASH at the healthcare facilities. And that will require a lot of partners, that will require a lot of commitment and maybe even changing behaviors ourselves on how we will deliver that. There are several initiatives that can be linked to our effort. Every mother, every newborn quality initiative. I'm sure you heard as well about the Global Action Plan to eliminate childhood pneumonia and diarrhea. All of those plans include, obviously, access to safe water and sanitation. HIV/AIDS needs to have improved access to safe water and sanitation. And now the Ebola outbreak has demonstrated, again, something that we all knew, that without a proper health system in place with the basic public health minimum standards, there is no way to control outbreaks or to respond to an infectious disease that is challenging the countries affected at the moment and causing such a distress. And obviously, there is an opportunity for more synergies, more coordination, more coherence, but it's something that is ambitious, but is very much feasible. And hopefully, the fact that we can link our efforts to the universal health coverage. As you know, this is one of the things we are promoting for the Sustainable Development Goals. Under universal health coverage, you need to have not only the curative services that you need, but you need to have as well access to the preventive measures, the protective and prevention, and therefore access to safe water and sanitation. Nobody will discuss that this is a basic primary prevention strategy and an approach that cannot be missed. We believe that many areas needs to be strengthened, and we are working on trying to address that. Areas that needs to be strengthened are national, obviously global efforts, and those are very much around this the opportunity that the Sustainable Development Goals will provide us. I'm sure you are aware of what is proposed by the WASH community as indicators for the Sustainable Development Goals, and although there are ambitious. I don't think they are actually. I mean, pretending to stop open defecation by 2030, or pretending to ensure universal coverage of water and sanitation at the healthcare facilities, schools, and households shouldn't be ambitious. Shouldn't be a minimum basic requirement. And I think we can all move into this direction. We have to monitor what we are doing, and we have to be very consistent with those monitoring mechanisms. They are already quite good systems in place to monitor, but they are maybe a little bit limited on geographic scope, so we need to sort it out that. We had only data for 53 countries when we did our global survey, and we need to go for more, and we need to use that for a proper monitoring. But more than that, we need to make sure that there is implementation at the country level. At national level, those standards will require technical support, will require to be feasible at national level and obviously implemented. And we need to help the countries to assess those risks and to make in place a facility for the WASH community to talk to the health community and make sure that they all work in the same direction. The capacity building on WASH should be closely developed with the infection prevention and control measures and ensure that there will be appropriate training for hygiene and the policies are, if possible, consistent. I agree that putting that word and putting all the dots together is always the most difficult thing. Major infrastructure improvements might take time, and that's clear, but this is not a reason that should stop us for a start to do and moving on more action on that. The enormous needs of WASH for healthcare facilities are now demanding us to go for more action. Obviously, we don't have the financial and human resources we need for that. But if we do a global advocacy campaign, if we prove once again that this is a question of human rights, this is one of the most and the best cost-effective investment, and if we put together all the regional offices, the country offices, the different partners and institutions that are contributing to this, and such as WaterAid or the London School of Hygiene and Tropical Medicine and many others that I'm sure is here, definitely DFID, can contribute enormously, I think is something that is feasible. All partners are very much needed. Obviously, the governments will have a key role to play, and non-governmental organizations, academia, donors will help to address these massive needs and ensure the rapid gains that are very much needed. So urgent action is needed. We all know that, and I think we should start now. For those of you who like movies, I'm sure that you have noticed that in every movie where there is a pregnant woman about to deliver, there is always panic, and there is always somebody saying, "Water, I need hot water." Nobody knows why, but they always ask for hot water. And in fact, that was confirmed by my taxi driver in Peru last week at the Climate Change Summit. He asked me what I was doing there, and I told him I was a doctor, and he says, "Oh, you know, I have a woman delivering into my taxi last week." And I said, "What did you do?" And he says, "Well, I called the ambulance and I asked for water." And I said, "Fantastic, that was exactly the thing to do." Actually, his taxi was still with some blood everywhere, so probably he didn't have water enough to take care of that. But the woman was alive and the baby as well, so those are the good news. So thank you very much for the invitation to be here this afternoon, and thank you all. If I leave, it's not because I disagree with the panel members, it's because I have to catch a plane. But I will be very discreet on my way out. And my colleague from WHO, Maggie Montgomery, I'm sure she will be ready to respond questions later on if there are. Thank you so much for your attention. Thank you.
Thanks, Maria. That's really fantastic, and really nice. As Jane has already said, to see WHO taking a leadership role on this. Towards the end of your comments, you said this is achievable, and there are important things for everyone to do. And I think it's quite a sort of strong conclusion. We're going to hear now from three authors from the paper, as well as the deputy editor of PLOS Medicine. We do want to make sure that there's time for questions and comments from the audience. So we're going to keep it really brief with our panelists. I'm going to ask for Jane and Maria, for as long as you can, to stay down here. And then when we go to the audience, I think we'll take questions and we'll interact, as makes sense. So the first person that I'd like to bring into this discussion is Yael Velleman from WaterAid, and Yael, as well as being a senior policy analyst at the NGO WaterAid, was the lead author of this paper. And congratulations for pulling this off. Really is quite something. As the lead author of this paper, I'd like you, for the benefit of the audience, because I imagine not everyone's read every word of the paper just yet, but as the lead author of the paper, I'd like you to distill this call to action down to the really critical points. And in particular, if you in the paper, you talk a lot about this opportunity around the Sustainable Development Goals. And Jane's made a good point that we don't want to just focus on the Sustainable Development Goals. But in order to pull out those critical points, if you could just tell me what this paper says to the emerging SDG agenda.
Thanks, Ollie, and thanks everyone for being here. There'll be a test in the end. I hope you're paying attention. So firstly, I just want to agree with some of the points that have been made. And Jane, as you say, it's not just about policy makers, but also about policy shapers. And in the paper, there's actually a very detailed table full of policy recommendations at different levels. So if you don't hear what you're expecting to hear from me, I promise you it's in here. That's why this took 2 years to put together. But just in terms of what we're actually proposing, in terms of the high-level policy recommendations, so firstly, in terms of the post-2015 or Sustainable Development Goal agenda, as you say, Jane, it's not the only opportunity, and I think Dr. Nera and in the paper we've proposed other opportunities as well that need to be taken into consideration. But I do think that the post-2015 moment is really an important junction at which we can try and put behind some of the more fragmented or siloed approaches to maternal and newborn health that have characterized the last couple of decades. And I don't think that anyone would argue that this has been very much the case, and possibly why we're seeing such slow progress on maternal and newborn health, especially since those are issues of inequality and that affect the poorest and most marginalized the most. What we're asking for is actually quite simple, and it won't take a lot to change. It certainly won't take a lot of new money. Firstly, I think what we are arguing for is that there's got to be commitment for universality. And what do we mean by universality is not just that we're going to pick out the people who are easiest to reach. Okay, they might be poor, but they won't be the poorest. What we call the low-hanging fruit. It's got to be everybody. And everybody, everywhere, has to have access to water, sanitation, and hygiene by 2030. And that includes healthcare facilities, as well as schools and other public spaces, because people don't just stay at home all the time. The other issue is that we're aware that we had a water and sanitation goal in the MDG framework, and we had a goal on maternal health, and still we're not quite there. And I guess the biggest problem has been not joining the dots. Everyone is aware of the truism that what gets measured gets done. So this time around, we've got to get the indicators right. And building in cross-cutting indicators, not just on the outcomes or the impact, so how many fewer mothers are dying and how many fewer babies are dying, but how are we doing on the things that determine those outcomes? That means that whatever health goal we have has to include data on water, sanitation and hygiene, and whether or not the systems that we're using to deliver on these impact goals are fit for purpose. And as Dr. Nera pointed out, what the Ebola outbreak has shown us is that there's really not been enough focus on strengthening health systems. In terms of monitoring, as you say, Dr. Nera, this is really where the crux of the problem is. And as you pointed out, data from, I think it's 54, 53 in the end countries shows that there's very little access to water in healthcare facilities. But actually, that's only 54 countries that we know about. What about all the rest? There's simply no data. We don't know. We don't know whether there's enough water in the delivery rooms, for example. We don't know whether or not there's adequate sanitation and drainage and laundry and healthy and safe food in those healthcare facilities, whether mothers are being asked to bring their own water into facilities, which is what Georgia and I have witnessed in countries such as Tanzania. So the indicators have to cover not just the impact, but the determinants as well. I'm running out of time, so there are two extra points that I want to make that I think go hand in hand with the post-2015 agenda. The first one is about development finance, and I think we can all acknowledge that there is room for making development finance or aid that goes into health and to water and sanitation more effective, more flexible in responding to country needs, so that we're not just putting money into one issue without addressing the issues that contribute to that. So funding towards maternal and newborn health has to enable health systems to encompass all the aspects that contribute to it. And then finally, as you've mentioned as well, the universal health coverage agenda, which I'm sure most of you are aware of, that gives us a really important opportunity, in my view, which we haven't had for the last couple of decades, and that's putting public health firmly back on the agenda. Not just talking about diseases, but talking about services that are fit for purpose and deliver all the different interventions that contribute to health. And it enables us to talk about water and sanitation and hygiene in a bigger way, not just in terms of preventing disease such as diarrhea and pneumonia, but also in terms of improving healthcare services that respond to what people need and that people want to use. Because what's the point in having healthcare facilities if people think they're too dirty to be able to give birth in? So that's just a quick overview of what we're calling for, but please do read the paper. Thanks.
Thank you. So I think there's a round of applause for some great comments, but also for pulling off the paper after the best part of 2 years. I mean, I think what you set out there, Yael, is, there is a way forward here. There are things which, clearly could be done to improve this situation. From my own experience, you get to a certain point with policy audiences where you hit a question, which is, so what's your evidence? And we're very lucky to have Una Campbell here, who's a professor of epidemiology and reproductive health here at the London School. And as well as having decades of experience in the field of maternal and reproductive health, you also, I guess, in the last 18 months, have looked at this question of, so what's the evidence around WASH in maternal and neonatal health, publishing a number of papers with colleagues such as Lenka Bonova here at the school. So my question, Una, if you would, and you only have 3 minutes to respond. What is the strength of evidence here that's underpinning this call to action?
Okay. Thanks, Ollie. A few years ago, 2 colleagues here in the audience came to me and said, can we look at the evidence base linking water, sanitation, and hygiene to maternal health? And I thought, these silly people who want to connect dots. And thinking about it, I think, in fact, what they were proposing were not dots, but sort of seeds, because as I sort of thought about it over time, I thought, well, let's see, what information is already there? What information can we pull together really quickly? And I think that there's a good and growing evidence base that we can rely on, and we've summarized some of this in this little booklet that you have here. These are all open access journal articles, so you'll all be able to look at them if you want. But to use up more of my 3 minutes, I'll just say we did a number of things. So the first thing we did was actually a systematic review where we looked for links between WASH and maternal mortality. And what we found was there were 14 studies. Some of these were ecological studies, so they're just looking at correlations between levels of maternal mortality and levels of water or levels of sanitation. But we also found a number of individual level studies which used better approaches and tried to adjust for some of the confounders that might be important. And what they showed, a meta-analysis of these studies showed that there was a link, an association between having poor sanitation and having an increased risk of maternal death of about 3. So women who lived in households, or women who lived in households with poor sanitation, were about 3 times more likely to die than women who lived in houses with adequate sanitation. And this is taking into account other things like their educational level and their income level. When we looked at the association between having inadequate water and maternal mortality, we found an association of about 1.5, so they're about 50% more likely to experience maternal mortality. Now, these were rather limited number of studies. None of them had been designed to do this. And so we then did our own study. We used secondary data from Afghanistan, led by Georgia as part of her MSc here. And what we found there was an association, an adjusted association of 2.5 with sanitation. This wasn't statistically significant, but our numbers were small. So having poor sanitation, you were 2.5 times more likely to die, and an association of nearly 2 for households that had poor water and maternal mortality. And there are 2 similar studies that are underway using information from Bangladesh and Pakistan. They aren't published yet, but we're seeing the same kind of links. And these are quite big effects that we're seeing. Now, how does this work? Well, we spent some time thinking about, is this really just a measure for wealth or poverty? Are these just really very marginalized and disadvantaged women and they're dying for other reasons? And we did a systematic review systematic scoping review, I suppose, and a conceptual framework which tried to think, okay, what are the mechanisms through which poor sanitation or poor water could link to maternal health outcomes? And here we broadened it to look not just at maternal mortality, but other measures of health, and health particularly of the fetus and the newborn. And what we identified were a total of 77 different potential mechanisms. 67 of them were chemical or biological linked to infections, for example, or linked to substances in the water such as arsenic. But we also identified 10 behavioral mechanisms that also could potentially have an impact. Now, the evidence here, for some of these areas we have strong systematic reviews, but many of them need more and further investigation and a quantification of the relevance and the importance of these. So this is an area where I think there's much more scope for work to be done. And then the final thing we tried to answer is, why is this important? And I think we've heard very much in the earlier presentations why this is important. But one thing we did was we also tried to look in depth in one country about what was the situation actually like. And we did this analysis in Tanzania. It was an illustrative analysis to show the burden of poor water and sanitation in childbirth locations. And what we found is that overall, only 1/3 of births take place in environments that are water and sanitation safe. For home births, it was only 1.5% of births take place in a home where there's adequate water and sanitation. And for facilities, it was 69% of births. When we actually looked at facilities themselves, only 1/4 had running water, soap, and access to a latrine. Okay, but some of these were very small facilities, and most of the births take place in big ones. So as a result of pulling all this together, we were able to show that only 1/3 of births take place in this adequate water and sanitation environment. So I guess to sort of summarize, I think there is a good evidence base, and it's growing, but I think we also look to all of you to contribute new research to help strengthen it.
Okay. Thank you very much, Maria. I think you're going to slip out. Maggie, I don't know where you are, Maggie. Oh, hello. If you would like to come, if you want to join the panel, feel free. Okay, thanks, Una. There are a lot of numbers there, and I'd really recommend that you look at the papers that Una referred to. But really quite shockingly low levels of water sanitation coverage in facilities where births occur, but particularly at home. So only 1.5% of births occurring at home in Tanzania being in an environment where there is safe water and sanitation. Next, I'd like to go to Georgia. To give Georgia, Georgia gone, but to give Georgia full credit here. She only found out that she was going to be speaking about an hour and a half ago, and she's very kindly agreed to step in for Professor Wendy Graham from Aberdeen University. Unfortunately, is sick. However, we're really pleased to have Georgia here. You're a researcher based here at the London School, but you're also leading the research arm for a new initiative called the Soapbox Collaborative, which is really focused on this particular space. At the moment, as Yael referred to, you're currently leading a facility-based survey in Zanzibar to assess the status of WASH in all labour wards there. What I'd like you to talk about is, based on that experience, looking at WASH facilities in labour wards in low-income settings, what is it that's needed to make these health facilities safer and to improve maternal and neonatal health outcomes? In 3 minutes.
Thank you, Ollie. This works? Yeah. So I'm going to address 3 points, which very much represent the vision of Soapbox as a whole. The first one is really about making sure that we enable the environment for improvement at both policy and country programs. I say this because some of the results that came out of the research conducted were somehow negative. There were bad pictures represented, and this could create a blaming culture. However, we think that the best solution would actually to turn these results into a catalyst for change. And in fact, I was really lucky to go 2 weeks ago to Zanzibar, which is the project I'm involved in. And we conducted a workshop where we presented the results, and we facilitate a process that went from the results into developing actions. And the results were actually outstanding. They concentrated very much on making sure that improvement was in sight. And I think the key thing that made this happen was that from the beginning, this needs assessment that happened in Zanzibar was focused on an improvement process. So this is the first point. The second point I would like to address, although this has already been mentioned, is the need for more robust research. But I'm going to specifically talk about research which is multidisciplinary. This is very important because, as we all know, there are some key areas that are needed to improve. We know that these require improvements. I'm talking about making sure that appropriate behavior around cord care is practiced, hand hygiene, surfaces cleaning, and the knowledge is there that this will make a change. However, universally, we know that some of these practices are not done. Even in Western countries, hand hygiene compliance is somehow low, especially in some places. And of course, it's important that equipment is there, but another important thing is that behavior is incentivized and motivated for this to happen. Hand hygiene is just one example, and in a lot of countries like the UK, health psychology and other behavioral sciences have stepped in to lead research on how to improve these behaviors. I think there is a niche for us to do the same in some low and middle income countries. So we need to bring forward disciplines such as health psychology and bring them into this field. The third area I'm going to focus on is making sure that improvement happens at all levels. I think if Professor Graham was here, she would say that no change is too small. And during the formative research that Soapbox has carried out this year, we've seen this all over the places, how important it is to involve local facilities, involve them in the improvement process, and how much ownership can change things at a local level. So on this note, thank you for listening.
Great, really crisp and clear, and absolutely bang on time. An example which hopefully Paul will follow. Dr. Paul Simpson is the deputy editor at PLOS Medicine, and we're really pleased to have the journal represented here at the launch. I'm going to read from your bio from the website just because it's great. Having mastered the dark arts of protein crystallography and working as a scientist at the MRC Laboratory of Molecular Biology, Paul decided to hang up his pipettes and learn a new dark art, that of scientific editing. So Paul, what I'm interested to hear about from you as the sort of last member of our panel, particularly given that you've moved from science to journalism, I guess, why is it that a scientific journal is publishing a call to action paper? We often think about call to action papers sort of coming out of more as the kind of the world of campaigning and activism. And I want to just, you could tell us, is this paper any different to these usual advocacy publications that we see? And in fact, is it something that influential people like Jane Edmondson and Maria Neira or Maggie Montgomery should take notice of? Okay, please.
Thanks very much. Yeah, that wasn't the biography I sent you, I don't think. I think that I've got the easiest question, actually, because of what's already been said before me. But you're right, it's not, you don't have to be an editor for very long before you've read very, very many call to actions. I think probably all journals, but all of the major medical journals receive very passionate calls for actions from, for very worthy causes. And so, when I was looking at the final product here in this paper, and I was thinking, there are some very clear, things here that make this stand out from other kind of calls for action. So, the two, WASH and maternal and neonatal health, are two sectors or two areas that the journal is very interested in. We've called for papers on these things already. But there is something very attractive about that call for reducing the fragmentation in research efforts and public health efforts, which a lot of these kind of call for actions is we need more, we always need more, and that isn't possible. So I think there's something very attractive there. I think the other thing that that we've heard from Una, I think, is that it did provide a very sober assessment of what we know, but also what we don't know. And I think that is very powerful because we really need to build an evidence base so that we can join those dots and get the most out of those collaborations. I think that it's been mentioned a couple of times, but there's the systematic review in tropical medicine and international health. I think that does tell you as much about what we don't know as what we do, and I think that's very powerful. There's very few articles where the authors will write, there is a dearth of rigorous research compared to modern standards, which I think is, that honesty I think is important. I think I've said this already, there's often this kind of call, we need to do something. And I think that you probably shouldn't have called it a call to action, you should have called it a pathway to action, because it does more than saying we need to do something. We do need to build that evidence base, and I think it does outline that very well. But there are also things that we can start doing now, which I think, again, has been touched on many times actually in the conversations that we've heard here. So I think the message is a powerful one, and I think that's why it deserves to be in a prominent journal, which I'm glad that it's PLOS Medicine that's published it. But I think the other thing about these types of calls is that they're not a blueprint. It's not a done deal. And what I think that all of the authors will want from is that this can be critiqued, it can be built on. This might not be the way. There might be better ways. And I think that if it can have as wide a possible reach, that's important. And so, something that's very kind of at the heart of PLOS, and I think that something that these research communities have embraced is open access to information. So what we hope is that, the PLOS Medicine paper, but also all of the other papers that have been published open access that provide a lot of the support for this paper will be sort of widely read, reproduced on people's websites and reused. So I think that there is a lot in this paper, actually. It does a lot. It doesn't just say we need to do something. It starts to actually tell us what we should do.
Okay, well, we started about 9 minutes late, and we're going to finish about 11 minutes late. Don't blame me, blame the people that arrived 9 minutes late. The reason I am going to abuse, my privilege as a chair is because you've all been sitting here very politely and quietly, and we'd really like to have an opportunity for some questions or indeed just comments from the audience. So if you could put your hand up if you've got something to... Yeah, okay. Val, please. Could you say who you are?
My name's Val Curtis. I'm one of the co-authors on the paper. I've been working, and thanks for this brilliant event and incredibly important message that's going out from here. Many years of trying, I suppose, 30 years of trying to get people to take hand washing seriously. It's been a mega struggle, but I guess we're getting there. We still don't have enough programs in the world actually doing it, but we have a lot more people talking about it. What have we learned from that? I think that you need to have the evidence about what we do know and what we don't know. We need success stories. We need some really nice flagship programs that are really creative and interesting and exciting, that tell great stories about what you can do to change the situation and evidence that it's worked. So when I go to a policymaker, I go, here's my randomized controlled trial results. Look, great result. And here's the great ad that we made or the great trick that we used. And people go, oh, yeah, that's clever. So people get it both on the intellectual level and on the emotional level. So I think we've got both. We need the evidence and we need the kind of emotional hooks that make people care about this and see that we really can make a difference. Head and heart.
Okay, great. I'm going to take one more question, then we'll give the panel a chance, please.
My name's Fiona Campbell. I'm a student here at the school, but I was working for a health agency before coming here. We were running programs, health-related health programs, but we were also trying to integrate WASH into them. But we had to look for additional support for the WASH because it wasn't included in the funding for the health aspects. So I was just wondering, we were trying to show the benefits of combining the two, but my question really is how can we make sure that the health funding available also allows for WASH elements to be included in programs?
Great. Okay. I'm going to get to so we've got a big panel here. So what I might do is push some of the questions to certain panel members. So I'm going to start with Val's question, which is, yes, you need evidence, but you also need, a sort of flagship, intervention, if you like, something you can put in front of people and say, look, we can do this. So I'm going to pick on DFID, who funds great programs, and WaterAid, that does great programs. So Jane, if you could just reflect on this point that Val's made. So I'm putting you on the spot here.
No, that's fine. Do you want me to answer this one over here?
If you'd like to, yeah.
That's kind of a bit of a donor question, isn't it? I think it's really. It was mentioned this importance of what gets measured gets done, and I think there's also something about. And this is something I heard that stuck in my head that somebody said about 3 months ago, is that's true, but what gets talked about gets measured. And so, there is sort of, it's all talk, it's no action, but sometimes the talking is the action. And when something's at the stage it is now on this particular topic where things are emerging, calls for action coming out, we've got examples of programs in DFID that are trying to do this now, but it's certainly not a universal thing. I think talking about it is actually one of the most important things to do. So I would definitely sort of say that I talk about it a lot through all sorts of avenues, because as I said before, policymakers come in all shapes and sizes. And so I think that's a really important thing to do. And I think on this thing about, how can you get room in programs, it's a real challenge. We get, and when I'm reviewing programs, we get asked to look through programs from a climate change lens, women's empowerment lens, education lens, it's just a health program, through multiple kinds of lenses, and you cannot possibly look at every program through every lens. You get a really bad headache. So I think it's what's said about is about identifying the most useful in any particular context as well. It's quite context specific. Working out what are the most useful dots to join up, either because the evidence is there that this is a really good thing to do, and because it's doable. There are things you can see that in that context can be done, and then just build the momentum
through doing those things. But you can't do it every time in every case, and so it's kind of, it's also about picking your moment.
Great. Yael, did you want to come in, and then I'll see if anybody else from the panel wants to join in.
Great, thanks. That's a difficult one. I'll come to it in a second. But Val, I couldn't agree more. And I think that there's a lot of very exciting stuff that's happening now that's taking that point and actually putting it into practice. The example of Zanzibar, which is a collaboration between WaterAid and Soapbox and the Ministry of Health in Zanzibar, is a very exciting one, because here we're seeing very high-level political commitment that's filtering through to all levels of the ministry and the health system, not because people are waking up to the fact that WASH is important, but because they're waking up to the fact that they won't meet their targets and their outcomes around maternal health if they don't change the way that they do business. And the learning from that, and especially the needs assessment tools that have been developed by Soapbox, is already generating the tools that we need in order to be able to run such programs. There's a lot of stuff that's happening, not just in Zanzibar, but also in Tanzania, mainland, in Cambodia, and PNG, work that WaterAid Australia has been leading, and Alison's shying in the audience, but also probably work that Maggie can talk about in Mali and other parts of the action plan. In terms of how do you get WASH funded as part of health, I think it becomes easier if what you're trying to fund is not WASH or maternal health or obstetric care or HIV, but you're funding health systems. And if what you're saying is we're funding health systems as a donor or as a government out of our own domestic resources, and you say a health system means all of these things, that question shouldn't arise. As far as I'm concerned, that's where the problem needs to be fixed and where the opportunity is now. But perhaps Una can say something about this as well, because I know you've done some great work around signal functions, around how do we know that a healthcare system is fit for purpose, and she knows more about this than I do.
Okay, Una, please do comment, and then Maggie, if you would like to come in, and then I'll give Georgia and Paul an opportunity, and then I think we're going to close.
Yeah, I mean, I think I agree also with what Jane said, that part of the way you get this going is to talk about it, and part of the way you talk about it is to get indicators. So there's, in the maternal health field, there's a way that we've been using for a long time that signals that a facility is capable of providing a certain kind of quality of emergency obstetric care. But we started to think, well, yeah, but at some basic level, you need this facility to have lighting and have water and have sanitation. And we've sort of proposed and suggested that these also be introduced as signal functions of a facility's capability to provide any kind of service. And I think by doing that, it's relatively simple. We have tools that do this in a number of countries. There's the WHO SARA tool. The EHS have a health service provision assessment, et cetera, and we can start to do this. But let's also use that information and talk about it and say, okay, only this percentage of facilities have that very basic general requirement that it takes to be a health facility.
Yes, so very quickly, great point, Val. I agree with you fully, and I think other examples are emerging. For example, from Mongolia and Vietnam, we're finding that they adopted the WHO standards, and they went out and were able to implement these standards and to ensure that health facilities, before they were even built, had the funds allocated to make sure WASH was included. And I think a lot of it is a political will. If countries have standards and they have policies in place, it's not a question of whether or not WASH is there. And I think we can all give examples of where you've been to hospitals and seen, you know, some new fancy building or piece of equipment, but there's no water. So it's not necessarily about resources, but it's about how they're allocated. And on the cost benefit, that evidence is out there. I think it's something like $5 benefit for every dollar invested in water and sanitation. So I don't think we are lacking evidence in terms of that area.
Georgia, just very quick last comment.
Yeah, I'm just going to say that within the facility settings, we're very lucky to learn from some of the behavioral sciences applied for hand hygiene, for example, in communities. So I think we've got a lot to build on, following on what Val said.
Paul, you get the last word.
The last word. Well, one of the things that, again, I'm sorry to sort of bang the open access drum, but I do think it's important that, and it fits with Val's comment, is that I think we need to make sure that when we do tell these stories, that the evidence is in them. And I think that, you know, one of the powerful things that researchers can do, and this is a good setting, is actually embrace open access, which this community has done, and make sure that, you know, it's available for those that need to see it, and also that they can reuse it, so it can be used by the NGOs to tell that story and, you know, to kind of pass on that message.
Great. Thanks, Paul. And a really good point to end on, which I'm going to pick up on, which is all of these papers are open access, which means that you can download them directly from the journal's websites. That's whether it's PLOS Medicine, PLOS One, or Tropical Medicine and International Health. If you do feel the need to get your hands on a hard copy immediately, there are copies outside, you know, which you can grab for your, you know, bus or train ride home. I want to just finish by saying thank you to all of our speakers, and before you put your hands together one last time, just to acknowledge as well Alexandra Chitty, who works here at the London School of Hygiene and Tropical Medicine, and really is, you know, the one person that made this happen, has been working really hard for the last month at least to make this happen. So if you wouldn't mind, you know. And I guess the real reason you're all here, there are mince pies, and there might even be some alcohol downstairs. Thank you.